It's 8 o'clock. Good evening, everybody, and welcome to today's episode of Marvelous Medicine. The topic is quality improvement in healthcare. It's everybody's business. Giving a talk will be Dr. Ankur Sooden. He's a project lead at John Snow India and is spearheading the private sector engagement strategy for USAID's SAMVEC project in India's vulnerable geographies. Dr. Ankur did his MBBS from Baba Farid University of Health Sciences, Punjab, and Masters in Health Management from IIHMR, Jaipur. His areas of interest are improving maternal, newborn, and child health in low-resource settings. He played a vital role in creating the nationwide quality of care network, which brought together around 3,000 healthcare providers and institutions. Dr. Ankur was an improvement advisor to UNICEF in Bangladesh and has worked with the World Health Organization on quality initiatives in many countries in South Asia and East Africa. I must thank Tilaka for introducing me to Dr. Ankur. A few weeks ago, I attended a weekend session on how to use in situ simulation for quality improvement. And and both Dr. Ankur and Dr. Manju were faculty in that course. And I was so blown away that I thought I must share it with my Marvelous Medicine audience. Thank you, Dr. Ankur, for readily accepting at very short notice to do this session. Moderating the session will be Dr. Manju Puri. She's the Director Professor, Department of Obstetrics and Gynecology at Lady Hardinge Medical College, Delhi. Dr. Manju did her MBBS and MD in Obstetrics Gynae from PGIMS, Rohtak. She's the President of NARCHI Delhi Branch, Subject Expert Committee, Central Drug Standard Control Organization, member National AEFI and Signal Review Committees, and is also an external quality assessor in public health facilities. Dr. Manju received her honorary FRCOG, Foxy Achiever Award, and APJ Abdul Kalam Excellence Award in just last year. So if I have to enumerate all the awards she has received, it will take too much time. She has over 175 publications and has edited 3 books. Despite being a senior faculty at a very famous institute, Dr. Manju Puri is incredibly humble, and her enthusiasm can beat any first-year postgraduate. Her excitement is contagious, and that's how I felt that everyone will benefit from her participation today on quality improvement. Thank you, Dr. Manju, for accepting our invitation despite your busy schedule. Over to you, Dr. Ankur.
Thank you, Dr. Vidya. Thank you for having me here. So, welcome to all of the Marvelous Medicine family members who've joined here on this Zoom call, and also those who are watching us on the live that is being streamed on Facebook, I guess. So let me quickly share my screen and we go on from there. I guess my screen is visible now.
Yes, Dr. Ankur.
Right. So, hi everyone. My name is Ankur. I lead a project called SAMVEC in John Snow India Private Limited. And thank you, Dr. Vidya, for such a long bio. I would shorten it up by saying that all I do is I simplify quality for clinicians. If I have one job, that is to make sure that clinicians understand quality, clinicians own quality, and they improve quality of care in their own sphere of influence, in their own units. So I have been trying to do that for the last about a decade, and let me try to do it again with you today. My effort would be to ensure that by the end of this, you have a very clear understanding on what is meant by quality improvement or what is meant by quality of care, and that you get interested in improving quality of care in your own units. So I work for a project called SAMVEC. We try to improve maternal, newborn, and child health in some of the vulnerable geographies in India, particularly with the private sector in low resource settings. It's a US government funded project, and we have multiple partners in this project whose logos are visible here. So I'll start by the very basics. We need to get the basics straight before we can understand what we can in terms of quality of care. So what exactly is quality of care? Well, if things are done the way they are intended to be done, we would call it quality of care. So all of evidence-based medicine that each one of you practices is based on solid scientific evidence. So as long as the health services that we provide to individuals or to populations, they increase the likelihood of they're getting better or their desired health outcomes, and they're what we do is based on the latest evidence-based professional knowledge, we would call it quality of care. So there is evidence and there is practice. As long as they both match, or the degree to which they match is really quality of care. So, when would you call that a health service is good quality? When it is effective. If I come for the treatment of a disease or a disorder, it gets treated, uh, and it's based on evidence. It's safe. So I get what I want from healthcare. I do not get any unintended consequences of healthcare. So it should be safe. There is no unintended harm, and then it is people centered. It is the care I get is based on my individual preferences, my needs, and my values. So as long as care is all these three things, I can call that care or that health service good quality. But to do this, it's important to ensure that health services must be timely. I get the care when I want. I do not get it later. It's equitable. I am not discriminated in terms of who I am, where I come from, what socioeconomic status I am, or what caste, color, creed I am. It's integrated. The care is not fragmented, right? Wherein I go to a primary healthcare center or a clinic, I get some care there, but then suddenly I need a better care. I have to go somewhere else. And these two are not integrated. And as a client, as a patient, I have to run between the pillars of health system that are there in the country. So if it's integrated across the range of services and it is integrated across the life course, uh, you know, that's when we would call it good quality. And then it is efficient. A lot of resources go into providing healthcare. A lot of resources of individuals go into seeking healthcare. So a healthcare service that is efficient, which uses resources wisely, avoids waste, is certainly required for it to be good quality. So I've sort of tried to define what good quality healthcare is, but let's now, face the facts as to how is the overall quality of care. So for the last about 15 years, there has been stagnation in how much care is in line with the best evidence or guidelines. And that has been stuck around 50 to 60%. So of the care we get, only half of it is based on the latest evidence or the latest guidelines. About one third of medical treatments are either harmful or they are not useful, which means it's a wastage of resources in terms of time and money. The rate of adverse events in healthcare also has remained nearly stagnant for more than 2 decades now, for which we have data, and which is around 10%. But then all of these numbers that I'm giving you are from high income countries. These are from Northern America or Europe, all high income countries which have more access to resources, and not just financial resources, but also technical resources. So this is the situation in high income countries where there are a lot of resources. So guess what it would be the case in lower middle income countries like the one that we live in. So there's a global commission that was set up to look into quality of healthcare. Uh, this appears a very complicated map of the world, but to make it very simple, the darker the color is, the poorer the quality of care in that area is. And this study was done across low and middle income countries. As you would see, Europe and Northern America is excluded from here. So India, as you can see, is pretty dark in color, right? So mortality that is ascribable to poor quality of care is pretty high in this country. And a question to ask you would be, what do you think kills more people? Is it not getting access to care or not being able to utilize care, or being able to utilize care but care which is poor quality? Sadly, my friends, more people die because of poor quality of care than because of non-utilization of health. And this is true across the globe as well as in India, right? So again, a lot of numbers on this slide, but if you focus on the last column, which says of all the deaths that can be prevented by healthcare, what percentage are due to poor quality? So 66% in India, which is higher than neighboring Bangladesh, higher than entire South Asia, and higher, higher than the average of all low and middle countries. So a lot of people die unnecessarily because of poor quality of care. Nearly two-thirds of death that healthcare can prevent can be ascribed purely to poor quality of care. And when I say poor quality, I would want to repeat, it means care which is not up to the latest evidence-based standards or guidelines. So poor quality of care contributes to death in multiple disease areas, right? But just to highlight, what are the major areas. So hospitalization itself leads to many adverse events. If you are in a hospital, you go with a medical condition, there's quite high chance that there could be an adverse event which is preventable and which does not give you better health, but actually increases your risk of poor health. A lot of deaths, in millions, happen because of poor quality of care, right? And here we have tried to put in this graph what is the total number of deaths that are happening which can be prevented by healthcare, and out of them, how many are because of poor quality. So if you see the largest or the tallest bar here, in trauma, of all the deaths that are happening due to trauma, nearly two-thirds of them are quality-related deaths. So there are many disease areas where poor quality contributes more than it does in other areas. So when I say quality, my diagnosis and my treatment should be in terms of what the evidence-based guidelines are. These two graphs, they tell you about what percentage of what is to be done is being done in family planning, in sick child care, in antenatal care, or in delivery care. And then, it divides by various countries. As you would see, in terms of proportions of items fulfilled, or the number of things you have to do to call the care you give good quality, is rarely more than 60%. Even for specific conditions in maternal and newborn child health, if you look at the diagnostic accuracy, that really, leaves a lot to be desired. So if you look at the B graph here, in malaria and anemia, the correct diagnosis happens only in about 20%. So that's really the situation. But then if, quality of good quality care should be done and good quality care is not being done, who do you think is responsible for such poor quality of care? I mean, when I'm talking to healthcare providers, when I'm talking to all you doctors, you might believe that, is it you who is responsible for that? So there are a few points I want to make very clear. All healthcare providers, including yourself, you work within systems that make it impossible not to provide poor quality of care. Nobody intends to do poor quality of care. I don't know of any doctor, nurse, or healthcare provider who gets up in the morning, gets ready for the day, and then thinks that, okay, today I'll go to my healthcare facility or my clinic or my hospital and do poor quality of care. So nobody intends to do poor quality of care, but we work within systems which make it impossible for us not to provide poor quality care. So we must pay attention to the design of these systems that will help us understand the behavior of healthcare providers or their performance. An easy way to understand this is, for those of you who have worked in more than one clinic or more than one healthcare setting, the quality of care you are able to deliver varies. Even though you are the same individual, it varies between different settings, it varies between different hospitals. So the system of care in which you provide care is really very important factor in deciding whether or not you're able to do good quality care. So if you want to change the result of a system, you need to change the design of it. You can't just get by, by only changing the healthcare provider. If you want to change the output of a system, which, the desired output here is good quality care, you have to modify the present situation, right? So, quality improvement, the topic of today, the thing I'll talk about in more detail, it's not about changing healthcare providers. It is not about changing people. It is about changing systems. And in a while, I'll help you understand what do I mean by systems. So this is a very famous Donabedian model. Avedis Donabedian is called to be the father of quality, father of healthcare quality. And this is from the last century, 1988. So helping you understand it very simply, in any system, any healthcare system, there's really three things. There's the structure. Structure is all the fixed things which you have to call some place a healthcare facility. So which requires, all the facilities, equipment, building, drugs, all the, trained human resources, the organization structure. So the context in which care is provided, or, in simple words, you can say the hospital or the clinic with all of the, all of its essential components is really the structure. Now, within this structure, care doesn't happen automatically. There are certain processes of care, things that healthcare providers do, or things that happen during the interaction between healthcare providers and clients, right? So, the care seeking behavior of the clients, then the diagnosis, and then finally the treatment that we do. So, if structures are good and the processes of care align with the latest evidence based guidelines, then likely the outcome of care would be good. The outcome of care is a patient is cured of their disease, they are able to enjoy their health to the fullest, and not just physical health, they are also satisfied. So it is not just the provision of care, but also the experience of care is good, and their knowledge also gets better. So likely they are to, in future they will engage in healthy behaviors. So this really is the system. But let's try and understand, like I said a little while ago, the current systems of care make it impossible not to provide, poor quality of care. So we need to change this system. So we'll go into a little detail about understanding what these systems are, and as an individual healthcare provider, what can I do to improve this system? So again, who is responsible for poor quality of care? I'm not saying that healthcare providers are not responsible because it's a nice thing to say. A lot of research has gone into this. There was a global committee on improving the quality of healthcare globally, and after years of research and a review of what has happened across the globe, what they finally concluded is that the study committee it vehemently rejects the idea that the workforce, the healthcare provider, is generally at neglectful or is uncaring, right? So, even a global committee finally decided what might be common sense to you, that there is no healthcare provider who wants to do poor quality care, or wants to neglect care, or is uncaring, or is generally at fault, right? So you really can't blame healthcare providers for it. Many of the healthcare providers, or the would-be healers of the world, they are ill-served by being embedded in and being dependent on systems of care that impede excellence rather than supporting it, and systems which drain your energy rather than nurture it, right? So, just helping you understand this even better, as I said earlier, there is no healthcare provider who wants to do poor quality of care, but poor quality of care does happen. So the responsibility for poor quality of care might not be a healthcare provider's, but I want you to understand that the systems are responsible for poor quality of care, but these systems won't improve unless or until the healthcare providers take charge. They take control of these systems and they understand these care systems, and they work consciously to improve them. So even though as a healthcare provider, I'm not responsible for poor quality of care, I'm actually a victim of the system, but the system will improve only when I try to improve it. And that has to be a very conscious effort. I can't have a wishful thinking that, I'll get a system of care which will allow excellence and I'll deliver, the best quality of care. I'll have to actively work to improve that system of care. So why healthcare is, why providing healthcare is a little difficult can be understood by the fact that healthcare systems are not simple, they're not complicated, they're actually complex. So a simple thing is like baking a cake. So, simple system, baking a cake, there's a fixed recipe, you follow the recipe, there is a high degree of certainty that you will get a cake like you desired. But if I talk about complicated systems are systems which require a little more effort. So, for example, unmanned spaceflight or sending a rocket to the moon, right? Now, it's complicated. It's not as simple as baking a cake. There's a high level of technical expertise required, and there's also detailed instructions. Where will you place the rocket? When will you, ignite it? What fuel would you use? What velocity? What is the escape velocity? Where it would go? So there's a lot of details required. So, I guess around 5,000 years of the existence of modern human, it took us nearly 5,000 years to get a flight to the moon, the first one. But when did the second one go? Perhaps, a year later or a few months later. So doing it first time is difficult, but once you create a detailed set of instructions and you develop high technical expertise, you can repeat it again and again, right? It's like, creating guidelines. So it takes a lot of time to create a guideline, but once you create it, you can, if you follow the guideline to the T, chances are you'll get those results every time. There's a reasonable degree of certainty that, you will get the result you got the first time. And as you get experience, chances of success become even higher. But there are some things like the healthcare systems that are neither simple nor complicated. They are a degree further. They are complex. A good example of something complex is raising children. Human beings, we modern human beings have been raising children from the time we have been around here. There are no fixed recipes. Those of you who have seen more than one child in your family, the second one isn't necessarily easier than the first one, right? Every child is unique. Every child is a unique individual and has to be understood as an individual. It's as easy or as difficult as in the first one. There is a lot of uncertainty about the outcome, even if you follow some of the instructions. I don't know of a perfect recipe to raise children yet. So it's been as difficult as it would have been for our forefathers, and probably it will continue to be. So, just wanted to give a lighthearted example to help you understand that one of the fundamental mistakes we make in healthcare is we think healthcare is complicated. We can make a nice SOP, a wonderful guideline with all details, and then it will work, right? It might work in A hospital and it might not work in B hospital, right? Because the context becomes the king. The context changes. Each patient is different. Each context is different. So that's a reason why guidelines do not help, right? And there has to be a conscious effort for contextualization of a guideline in a particular context, right? So this is a common mistake that I would request you to avoid. Guidelines are very useful, but they can only guide you. They can't handhold you through the healthcare quality problem that you're facing, right? They can only give you a general direction as to where you have to go. A guideline can tell you what the latest evidence says about what practices work for improving a certain specific health outcome or treating or diagnosing a certain specific disease condition. But it still requires an intelligent person with autonomy, with a clear purpose in the head, and with all the tools required to deliver care, right? So the point to remember from this slide, healthcare systems are complex, right? So it requires much more agility. It requires much more decentralization of decision making. A guideline seems like a great solution. It won't work. Also, when we try to improve healthcare, one of the problem is that change is usually led by somebody who does not belong in the process of care. Quite commonly, this is the quality department in a hospital. If the quality department wants me to improve the quality of care. My understanding and my experience is that usually doesn't work as well. Change has to come from within. As human beings, we are naturally resistant to any change, right? So who wants better quality healthcare? Each one of us. But who wants to get involved in the day-to-day changes which will result in better quality of care? Maybe not me. So that's precisely because of human tendency to resist any change, right? So, given that healthcare quality is not what it should be, it's really bad. And given the fact that as healthcare providers, we are not responsible for poor quality of care. The system is responsible, but also the system will not change unless we consciously change it continuously, right? So what should we do then? Do we just end this presentation, think that this cannot be achieved? But there are ways to improve, right? So what can we do to improve care? Very generally, you won't be able to do it alone. You have to find like-minded people who are interested in solving the same quality problem that you want to. So you need to team up with others. You need to develop systems thinking. Systems thinking might be a big word, but basically you need to understand patterns, right? If in my maternity operation theater, I'm getting a lot of follow-up cases in my dressing room with surgical site infections, it's not just individual cases. I must recognize that there is a pattern here. Something is wrong. As doctors, we zoom into each case and each eventuality and individual patient care. We sometimes forget to zoom out beyond the individual patient care, understand our system of care. There's a hospital where the surgical site infection rates after total knee replacement is about 2 or 3%, and there is my hospital where it is 6 or 7%. Now, this problem will not be solved by attending to each individual patient care. You have to understand where my system is going wrong, right? So you have to identify or look at your work in terms of the system of care. Who comes into this system, who goes out, what are the outcomes, what are my processes of care, what I need to fix so that my overall system improves. So you have to look at it as a system and look at it beyond just individual patient care. Second, you have to use data. I understand all healthcare providers get involved a lot with data. We spend a lot of our time trying to do data, but most of it happens because we have been asked to do so. So what we really do in terms of data or in terms of recording is we do it because somebody needs it. Even in my recent visits to hospitals, and I've been working directly with hospitals for quite long now. In my recent visit to a very big hospital, what I saw was that in one of the intensive care units, there was data being reported on central line associated bloodstream infections and ventilator associated pneumonias. But interestingly, no clinical provider in that very big, very busy intensive care unit was actually looking into how many, what percentage of cases are getting infected. That data was primarily managed by an infection control nurse to report to the quality department. I don't know how that helps anybody. It might help the hospital in reporting during the quality assessment that, yes, we have a great reporting system. But the point is in using such data for improvement. It's not about recording and reporting only. So remember to look at patterns by using data and use data for improvement, not for complaining, not for fault finding, not for just reporting or recording in a register. Use data for improvement. Also, always question status quo. There is absolutely no hospital in this world which gives perfect care. I started with the numbers of poor quality care in high income countries, which have remained stagnant for more than a decade now. There is always a scope for improvement in every care system. You could decrease your infection rates, you could improve your waiting times, you could improve the outcomes of your surgeries, outcomes of your treatment. If you think your provision of care is really perfect, you can work on the experience of care, the client satisfaction around care. There is always a scope for improvement. but we'll need to, wear those lenses where we look at our work as systems so that we can identify what is it that can be improved. Also, since you all are, busy clinicians, there's so much to do. And suddenly, I come up one fine Thursday and tell you that now you also have to take control of improving quality. And, reasonably, you would think that that will increase my workload. Why should I take the workload? Let the quality department or somebody else do it, right? So, my humble submission is that quality improvement does not necessarily increase your work. Actually, it will decrease your work. If you identify waste within your system, you will be able to prevent harm. You will be able to improve efficiency. Like if I have less surgical site infections, I have less surgical site infections to attend to and focus more on the surgery rather than an unintended consequence of the surgery. If my waiting times get better and people get good care, they go home. I can take care of the next patient rather than focus only on them. So even if you are a very busy public health, system where there is unending demand, and there you can improve efficiency, more people can be taken care of. And if you are a for-profit institution, you work with one, improving efficiency will certainly improve your bottom lines, your financial bottom lines. So look at, identify, remove waste. I say it with a lot of confidence that there is a lot of care that is unnecessary. And among that, there is a lot of care that is actually harmful. Try and identify such waste. Every time I do not wash my hands before examining, and I think I've saved 30 seconds there. I do not realize that I actually will have to waste a lot of time in the infection that it will cause, right? So efficient care is also decreases your work. It does not necessarily increase it. So I think by now I've sort of helped you understand what is quality of care, the fact that quality of care is bad, and also that you are not responsible for poor quality of care. But importantly, you are responsible for improving the quality of care, right? And how you might do it, broad principles. But there is a lot of science into what works and what does not, when you're trying to improve quality of care. So, one of the most common ways of doing anything in healthcare settings is, this is not happening, this may be because of lack of training, let's train our staff. So I want to show you some evidence. There's a research that has happened into how do we improve the performance of healthcare providers, or how do we improve performance of healthcare systems. So there's a lot of papers on that. Multiple strategies that have been used have been studied, and have been studied in low and middle income countries like the one that we live in, right? So all of this research points out to the fact that there's many things we try to do to improve, quality or improve practices of healthcare providers, right? So I'll show you a table where I'll show you some of the interventions that organizations do, and I'll show you their median effect size, like by what percentage points would it change anything. So interventions listed are, if you're going to give only printed information, that will change things only by 1% points. If you think handing out certain job aids or certain printed information will change anything, bad news is it will change it only by 1%. If you're going to use an information communication technology, let's send a guideline over WhatsApp to everybody, right? And that's the only thing we are going to do. 1% change only. If you think you're going to train your way out of poor quality of care, it works, right? But sadly, classroom training works only about 10%. If you think you can supervise, there's a huge cost to supervision. It does improve practices, but again by 15%. And if you combine these both, that is able to improve it by about 18%. Then if you come together as a group of healthcare providers trying to solve something, this group problem solving will improve things by a reasonable size. And then I can keep going on, but the point I want to make is, if you're going to use quality improvement, your effect size is going to be reasonable. And what are QI interventions? I'll delve into it. So I'll come to the good news. It's not all sad. There are solutions available. So I want to introduce all of you to the point of care quality improvement. It's a simplified methodology. It's been extensively used in the entire South Asian region where we live. It's adapted to the local context. And the basic principle with it is that it works on supporting frontline health workers. I'll give you a few examples. If you can pardon me for a minute, and then I'll just give you a few examples. So the entire, point of care quality improvement, it's basically a simplified way of quality improvement where we do not talk about big jargon, a lot of statistics, or complex things which are difficult for an everyday clinician to understand. It's a very simple method. Uh, Let me show you some examples of how it works. So this very complex chart, basically, if you look at these blue lines, this is the time that it takes in a suspected sepsis case from door to giving antibiotics. So the science here is that for any suspected case of sepsis, uh, antibiotic really should be given very quickly. That improves outcomes, that improves survival. So this is a very big teaching hospital. I'll tell you where you can find all of these studies toward the end. So we worked with them somewhere in 2019, and what we saw is that their door to antibiotic times could have been as high as 1,000 minutes. Ideally, it should not be more than a couple of hours. So any patient with a suspected sepsis coming to an emergency care or coming to an intensive care should get antibiotics pretty quickly. There are standards on that. So they worked on it. And finally they toyed around with multiple ideas on improving it. So they got together, they started screening people with suspected sepsis. They ran a teaching program for their own staff on how to identify a suspected case of sepsis and what to do in that case. And sometimes it's really the simple things which matter. So before giving an antibiotic, it's imperative to take a blood culture. And something as stupid as a blood culture bottle not being available was one of the key reasons why antibiotic was not given within time. Right. So they worked on all of these systems because they started looking at each of the case where antibiotic was not given the time, not as an individual case, but as a system of care which was failing these patients. And once they realized what the problem was, they got together, they used a simple method of point of care quality improvement. They were able to reduce their door to antibiotic time to well below the evidence-based guideline, which is around 120 minutes. So this is one example. I'm going to share another. This is again from a very big hospital. The 0, 2, 4, 6, 10, 12 that you see on the y-axis is average duration in months. For a case of infertility in a tertiary care hospital, these are the number of months it took before the infertility treatment could even start. So it was, close to 1 year. So a patient has come to a tertiary care hospital in, India's capital, and the time it took for them to even start the actual treatment was more than half a year. And you would well understand that, that is not helping anybody. So they worked on that. Again, I'll share where you can read this paper. But some of the reasons they figured out in their system of care was the fact that when hysterosalpingography gets done, because that's usually the definitive diagnosis before we can start treatment. The way it is scheduled, what day can you get it, how much delay is there, right? So they worked on all of this, and from a median waiting period of nearly 6 months before treatment could even start, they brought it down to nearly 1 month. right? So it's possible in even the busiest of settings, right? The thing is that it will always have to be led by healthcare providers, and they will have to use a certain method that I will talk about. This is another example, a very full slide, but what it tells you is about a very remote district in Bangladesh where I used to work. And the blue line that you can see running all across the screen is the percentage of babies who come to the sick newborn care unit and go back home healthy, right? So I worked with them over years to fix these systems, doing small things at a time. And since it was a low resource setting in a very busy setting, you really couldn't, uh, you couldn't throw dollars at the problem. You couldn't solve this by money or resources or more doctors. It's just not there. It is the remotest place in Bangladesh. The only thing you could do is look at systems of care and see why these babies are dying and how are we going to fix them. So their problem was that a lot of babies were dying. Others would not complete their treatment and go on a llama, or would be referred or just transferred to another hospital to die somewhere else. So we worked with them. We worked on some very basic interventions, evidence-based interventions, and how to strengthen them. Simple stuff like washing hands, kangaroo mother care, right? Thermal care for the babies, keeping the babies warm. So we started doing all of those things, and by, we were able to improve survival rates by nearly 100%. So coming back, I've talked time and again about systems of care and what do you need to improve. So, coming back again to the Donovan model, any system of care is the structures, the care setting, which is the building, the equipment, the drugs, the people, the employees, all of that combined, it's a care setting. Then there are processes of care. Processes of care really, diagnosis or the interaction between the provider and the client, because this is key. Unless this changes, the outcomes will not change. And the desired outcomes are, health outcomes or the experience of care. Now, very commonly in quality, what you would have seen is either accreditation or certification or inspection, as they call it, right? So somebody comes with a checklist, looks whether you are following those standards or not, and goes away. So what does that result in better outcomes? Let's try and understand. So let's say you are a JCI or NQuas or QCI or NABH certified facility, right? So what would be the basic difference in a facility that is certified to be good quality? So this certification might help you in identifying what are the gaps in your structure. So for example, the checklist says that in an ICU there must be so many doctors, these are equipment, these are drugs. So these checklists or this certification can help you identify what are the gaps in your inputs or in your structures, and you can fix them. It might also help you identify a gap in the process, or something that is wrong with the provider client interaction. But remember, an assessor or a certifier or an inspector sees the process or only some of the processes for probably only one day, maybe just one process, and tries to deduce information from that. So you possibly can identify some process gaps, but it is like giving an exam that doesn't automatically make a child intelligent, right? It only tells you the score of that day based on that question paper, right? So these processes of care will not automatically get fixed just because you are a certified facility, and therefore it may not lead to better health outcomes. So while quality certification has its benefits in terms of fixing the structures, possibly identifying some process gaps, that's really the limit of it. It doesn't improve the quality of outcomes on its own. So, helping you understand this again, what we all want is, improve patient health. The only thing that can directly improve patient health is the interaction between the provider and the patient. If the provider diagnoses correctly, does the right evidence-based treatment, then chances are that, patient health will improve. But how will you improve the interaction between the provider and the patient? So either give them more skills. I don't know how to do a surgery, teach me how to do a surgery. I don't know a new way of diagnosis, teach me how to do that diagnosis. And then also looking at my current process of care and helping me improve that process of care. So skills, clinical skills, and re-engineering of the current process. Those are the only two things which can improve the interaction between provider and patient. Of course, to those, to enhance those skills and do that healthcare process re-engineering, I need some standards and guidelines. I need to know what the evidence says. I need to know what the guidelines are. The organizational design has to allow me to learn more skills or to be able to change my process to make it better. Any effort at doing that will require leadership and management. And of course, incentives also work indirectly. But what you must understand is that neither guidelines nor incentives nor the organization design or a great leader will automatically improve patient health.
Yeah.
The processes of care have to improve the interaction between the provider and the patient.
குளிக்காம சாப்பிடாத.
And the culture in an organization has a big influence on all of that. That's a given, but good efforts can also change culture. So I'll again come back to some of the principles of improvement. Basic thing in improvement is that you must focus on the patient needs. How can a system improve for the patients? You must understand your work in terms of processes of care and in terms of systems. No expert, no quality expert, including somebody like me, can tell you what solutions are there to the healthcare quality problems you're facing. The solutions must come from people, from the providers or from the patients who are actually involved in care. You must use data to understand the situation and decide what to do next. And since you are trying to change something and you want improvement to happen, it's good to try whatever changes you think might be effective in your system at a small scale, to see whether they work or not, to see whether they are feasible or not, to see whether they are effective or not. So you must test them at small scale. Helping you understand the difference between quality assurance or quality certification versus quality improvement. Quality assurance or certification is usually externally driven. Either an external assessor will come or somebody from the quality department will come. They will measure and tell you, oh, you have passed or you have failed. You periodically measure past performance because they look at your records to tell you what your performance was. Quality improvement is slightly different. Quality improvement is proactively selecting a process to improve. It is always internally driven by people who are involved in care. And it is a continuous learning about today I improve this, then maybe this links with another area of care, then I improve that. And the point here is to exceed expectations, not just meet a certain standard. So you're making your system of care better than how it is today. So I'll give you an example of my experience in quality certification or assurance that might help you understand. So asking you all to guess, how many registers should a hospital ward maintain? You do a lot of recording, right? So how many registers do you think a hospital ward can maintain? So this is what I saw in a hospital. This is a list of all of their registers. So just to help you understand better, they had nearly 90 registers in just one ward, where in the daytime there are only 2 nurses and evening and night shift there is just 1 nurse. The funniest register I've ever seen is a register inventory register. Obviously when you have 90 registers, you need a register to keep a record of all of the registers you have. So what I want you to understand is quality does not mean unnecessary documentation. I've seen that happen across all kinds of facility, across all kinds of settings. Just because an inspection is to happen or a certification is supposed to happen, random documents are placed in a unit, in a ward. The healthcare provider has no idea why this is being done, but this is mandated, so we are doing it. I don't think that improves quality of care. That actually increases the burden on healthcare providers and does not lead to any change in any positive change in the quality of care you provide. Possibly it worsens it. So this is the 4-step approach I've been talking about. Any quality improvement method you see anywhere in the world, no matter by what name is it called, it's Kaizen, it's 5S, it's it's CQI, it's Six Sigma, you name it. anything can fit within this small 4 steps. Right? So the 4 steps really are: first, you need to identify what is the process of care, or what is the outcome of care that you're trying to improve. Right? You must identify something which is relevant to patient outcomes, does not require too much resources, something that your team is interested in doing, right? And something for which you can get a result in about 8 to 12 weeks and not more than that. You will need to form a small team of people who work in the processes of care. No, I can't improve the process of care in your system, and you can't improve processes of care in another system. It has to be people who actually carry out those processes, because they understand the problem, because they also have possibly the right solutions. Then you need to very clearly define what is it that you are trying to improve. Are you trying to reduce your door to antibiotic time? Are you trying to are you trying to decrease your infection rates? What is it that you are trying to do? You have to very clearly define it. Once you've done that, step 2 is, before making any change, you need to sit down carefully among your own team, try and understand why is what is happening, right? If my door to antibiotic time is low, why is that low? Nobody else can tell you. We can help you with tools, but ultimately you have to figure out why is that happening. It's because it takes a lot of time to take blood culture, and before that antibiotic cannot be given. And why is that happening? Because we have shortage of blood culture bottles. And why is that? Because my store issues me new blood culture bottles only when I submit the previous ones issued. And why is that? Because that is how things are here. So possibly you need to change that. So there are multiple tools here. I'm not delving into those, but the point is, you have to analyze why the quality of care is bad. There is always a root cause, and there are many stupid root causes for great problems, some of which are very easy to solve. You have to look at what are those causes. Parallelly, you also have to develop a measurement system. It's very simple. If you understand that if you get a patient, you first do a diagnosis. You also do a TPR chart or a HbA1c measurement or some measurement to see whether things are improving or not. Similarly, for your quality problem, you need to do some diagnosis, just like you do, you do an X-ray, you do lab tests, or you do clinical examination. Similarly, there are tools for analyzing quality issues. You do TPR charts, or you do, lab investigations. You look at them in a series, how they're changing. Similarly, for your quality issue, you need to measure the quality of care, and you need to look at your data over time, how it is changing. So once you've analyzed, you've figured out some root causes, you will have ideas on, okay, I'll solve it this way. And maybe your friend says that, no, I have another idea, I can solve it this way. So this is where I would suggest, please do not implement whatever comes to your head. Try it for a while. Trying will help you adapt it to your circumstances, help you get some confidence in whether this works on or not. Also will help you in avoiding some resistance that might happen to that change. People resist change when it is implemented. If you want them to try out something, maybe for a shift, try a different way of doing things, which you think might help, they will try that out. So you develop a lot of solutions or change ideas, and then you try them. So maybe for one problem that you identified, you have 5 root causes and you have 50 ideas. So you could try, each one of them once and again, and also learn from your trying to make your changes better, more contextual, more effective. We call them plan, do, study, act cycles, but you can conveniently forget the PDSA. The point is to think of solutions and try out solutions. And once you've tried out, 50 solutions, you know which 5 work, which 5 actually lead to improvement in quality of care as you are measuring it. You just continue to do that and you sustain improvement. So the why you must work on quality of care, I'll take another couple of slides and end. So why you must focus on quality of care, because just a building with some supplies and some providers is not healthcare, right? Healthcare is more than that. And if we don't ensure quality of care, what is the point of continuing to have more hospitals, more doctors, more clinics, right? The point is to get outcomes, and outcomes can be ensured only if quality of care is there, right? So people must get access to care, but they also must get good quality of care. Only then we can say that there is universal health coverage. Everybody gets the health coverage that they must get. So there are three resources that I want to leave you with. BMJ Open Quality is a famous journal. In this journal, there are a lot of quality improvement reports. The two examples I showed you, and then hundreds of similar examples are there. You can read them. That will help you understand quality improvement a little better. Some of those papers might appear very complicated. So my suggestion is look at their South Asia edition. So that will help you find, stories from hospitals similar to yours, and you can understand how they improve quality of care. And yeah, if you improve quality of care, you can publish your own paper also there. The second is the 4-step point of care quality improvement approach. Years ago, we collaborated with the World Health Organization to publish it. Its version 3 is out now. The entire learning in point of care quality improvement is based on an example which you will be able to relate to. So, and look for the WHO's point of care quality improvement manual. And if you are able to do these two, and you want to take your journey in improvement, much further, the improvement guide is really what we call the Bible of quality improvement. You can read it, and that's really advanced. It can continue to help you improve. So just 3 words to end my long talk. Improve health outcomes, right? Improving the hospitals is not enough. We need to improve the health outcomes for our clients. So I'll stop here. Thank you so much. Looking forward to your questions and discussions.
Thank you, Dr. Ankur. Over to you, Dr. Manju.
Thank you, Dr. Ankur, for a very, very lucid talk and introducing the concept of quality improvement. And I think very nicely you have stepwise built up the talk. And we all understand that the healthcare system is a complex system. We all want to change the system, especially those who are in the public sector. We know that we all would resist a change as well. So it is both ways. And I think it is important you've tried to put quality assurance and quality improvement separately, but actually both are interconnected. It is not that one is trying to bring down one and trying to lift up the other. So basically, quality assurance is something which provides us the gaps in the infrastructure. But a lot can be done, and we keep waiting, especially in the public sector, for the system to improve, for the infrastructure to improve, and we feel that nothing can be done. Because the system is so poor, there's no infrastructure, we keep harping that. But there are lots of things which are within our reach. And if we kind of use quality improvement actually would mean that, we are trying to fix the problem in the given resources. I think, let me put it like that. And that would be the best way of defining quality improvement. So we identify those where we are not waiting for everything to arrive and then do quality improvement. So we start working on whatever we have. So I think that is what is quality improvement from my point of view, which I think is important. And then we always feel that quality, certification and accreditation is something which is important. It is definitely important because it kind of puts the system in place. It tries to put the infrastructure in place. But then, it can't be that people at the top can, inculcate a culture of quality. So that quality improvement has to come from within. So, if I am in my ward, I am in my office, I am, in my home, there is something which is not going wrong there. So I identify that, I make a list of that, and then try and feel that this is something which I will start working on and I will fix it. So, that is where we kind of start it. So then I try to look at all the causes which are contributing to that. And then, fix and list, then, all those who are involved in that problem. So I would kind of collect all of them together, and we then make a team. It is not that I am trying to fix. If I say this is to be done, it will be done for a day or two. And then it kind of goes back like an elastic. So here, when everyone is a part, so everyone is kind of having a joint responsibility to fix that problem. And if that problem gets fixed, that everyone kind of rejoices. So it is a kind of, achievement for everyone. It is not only for the head of the department. So that is what I think is quality improvement. So each one gets into that, gets into the depth of it, kind of solves everything and then kind of, comes up. And then the other hassle is to maintain it, to sustain it. For that, we have to make changes in the systems. So I think a very good, presentation you have given in introducing the concept of quality improvement, which is everybody's business. So I love the tagline, Dr. Vidya. So it is everybody's business. And there are a lot of stories which we can share as clinicians, where we have been able to do things, which were next to impossible. So, but then we were able to kind of put them, straight. So thank you, Dr. Ankur, for a wonderful talk. And I hope that it will generate a lot of discussion. So over to you, Dr. Vidya.
Yeah, we have Dr. Shivkumar Singh, who's a specialty audit and improvement lead, as well as a clinical governance lead at his hospital in UK. Shiv, are you free to share your comments?
One second. Oh. Sorry, Vidya, 1 second. Yeah. Hi, Vidya. Yeah, I think Dr. Manjupuri got a bit distracted by what is called root cause analysis rather than quality improvement. I mean, I wish I could actually share my slides, because tomorrow actually it's nice to actually have this, because tomorrow I am actually giving an interview for the associate medical director for the audit and improvement for our trust. So I think the quality assurance is about benchmarking, right? So you say that the national levels of the healthcare, or you say community acquired infection or hospital infection, is around 3 to 5%. And you keep auditing yourself and saying that every monthly or 6 monthly or 3 monthly, that, oh, we are actually within that limit. That is our quality assurance, that we are assuring that we are not crossing that benchmark. That is quality assurance. Whereas quality improvement is that you say, well, we're doing really well for the last 4 or 5 years. Our health infections have been around 4 to 5% near it. I think we could do better. Let's move it to like 0 to 1%. Let's get better. That is what is quality improvement is. So your standard deviation actually moves to the left. So on the left side of the axis is that where you are doing really, really well. Then you have the benchmark, and then you have the bad. You don't want to be on the bad side of you don't want to be outlier. Okay, every time you become outlier, people, there is at least in UK, there is a knee-jerk reaction. I would say, why does it, even one infection will cause everything to go haywire, people will start looking at it. So that's what it is. But when you're talking about a problem and problem occurs within that, that's when you need to audit the process.
Right.
Yeah. And one of the important thing about clinical governance is that you need to actually have a system of reporting adverse events, which is not there in India. I know very few medical colleges, and I can proudly say that myself and Vidya come from one of those. And I remember even as a medical student actually attending morbidity and mortality meeting, where everybody was actually attending in one of the theaters in JIPMER. I mean, that's what is very, very important for clinical governance part of it. And that's where root cause analysis actually comes in. You go into the depth, why that death happened, or why that infection increase in our intensive care or critical care or on the cardiac. That is root cause analysis, looking at that problem. But these are, benchmarking is usually considered to be kind of a static thing. Okay, you every time collect data and say that, oh, we are within that. Whereas the quality improvement is a continuous process. It requires a lot of resources, manpower. Okay, the quality doesn't come cheap. You need to actually understand that. Everybody need to understand that quality does not come cheap. You can say that, yes, we can actually provide good quality care even with limited resources, and that is fantastic. That is what is quality improvement is. Within the resources, you actually giving a good quality. Your mortality rate came down to that was fantastic example where the neonatal mortality came down to almost 0% in Bangladesh. What a great achievement that is. That is quality improvement. Right.
Thanks, Shiv. Dr. PCV, you have your hand up. Would you like to say something?
can I just respond to this, Vidya?
Yeah. Yes, ma'am.
So thank you, Dr. Shiv Singh, for that. Basically, I am not a trained quality person. It is from me. It is like I have learned it with experience. But what you say is root cause analysis is absolutely fine. But I am taking it beyond the root cause analysis. So that is, we are trying to, when we have a root cause analysis. So if we don't have a system in place where there's, we do not have any adverse event reporting or anything. So it is not that we will wait for that system to come in place. We are, whatever, things are within my reach, I can always start fixing them with the help of, my team. So it is, even if I'm not at that benchmark, I'm not having very good, results, but I can still use quality improvement to improve upon wherever I am. So I improve from the level baseline for where I am by using a special methodology, which is involving a team and having everyone participating in it and solving the problem at our own level. So to my mind, I feel that is what is quality improvement.
No, that absolutely. I mean, absolutely, you're right. Now, if you look at how the audit programs or quality improvement program originate, they originate from adverse event. You identify that this is actually happening so often. You take into cause. You find the cause. What is what is causing this, and then that becomes your benchmark. You say, oh, this was happening, we eliminated this was happening, we eliminated. So that's where they actually come from. That's where the quality improvement projects come from. They come from adverse events. Those are the originators of the your quality improvement programs.
Dr. BCV?
Yeah, first of all, I like to congratulate Dr. Ankur, for giving the extensive lecture, because giving the lecture on the quality assurance in a 40 minutes of a lecture is a huge task. But Dr. Ankur had justified his talk by giving us all a very good elaborate measures how to handle the quality care. See, first of all, I like to introduce myself as an anesthesiologist. And even in this morning, in our own group, we started discussing about the pre-medication. See, as an anesthesiologist, 30 years before, I passed my anesthesia with a distinction by writing a short notes on the pre-medication as an essay notes.
Right.
So the pre-medication, if we look into that, we have to give them the antacids, we have to give them the antiemetics, we have to keep the patient starvation for a longer period. Everything was there. But if you ask me to write notes on the pre-medications, I will write just contradictory to what I written 30 years before.
Right.
See, the things are changing.
Right.
Traditional practice are changing. The problem of our physicians and the surgeons is to change from the tradition with the guidelines, with the evidences and everything. Now the pre-medication is wide. There is no need to give PPIs. There is no need to give antiemetics. There is no need to give analgesics, preemptive analgesics 1.5 hours before a surgical procedure. There is no need to keep the patient starvation for a longer period. 2 hours before, we can give them the preload of the carbohydrate. The evidences are very strong. The enhanced recovery after surgical procedures, the protocols are wide 15 years before it is proved. But still now, I can say it is not there in India, but it is not widely practiced even in other parts of the world. So pre-medication is given, starvation is continuing. And if you want to improve the quality care in a surgical patients, all these traditions has to go out.
Right.
And who is preventing the traditional practice to go away? It's our own surgeons, our own anesthesiologists, not ready to change. To improve the quality, we have to adopt the guidelines. And coming to the next example, the NABH protocols. We are accredited hospital for the NABH. The checklist is very clear. The checklist says before incision, after the surgery, All the checklists are there.
Mhm.
And before incision, if a nurse started asking us questions,
Mhm.
only the anesthesiologists are answering it.
Mhm.
When
Right.
you're asking the surgeons, have you
Mhm.
identified all among yourself? Can
Mhm.
you introduce the surgeons? Can you introduce your anesthesiologist? Can you introduce your head nurse? Who are the floor nurses? Nobody has the patience to listen and answer it.
Right.
And the moment the surgery is over, nobody is ready to answer the check out,
Right.
sign out.
Mhm.
Protocols are there. After
Mhm.
finishing the surgeries, they are getting the signature from us.
Mhm. Right.
We are signing it without answering anything. So
Right.
this is what the scenario. When the quality is we want to improve, we like to stick on to the guidelines, and the guidelines is not at all followed properly. So we all should understand. Like you just concluded your speech. Even Dr. Vidya has concluded the speech by saying that everyone is responsible for the improvement of the quality. The doctors, the staff nurses,
Right.
and all the people are responsible for improving the quality of the healthcare in the hospital. But we
Right.
are all not responsible for that, and we are lucid in that. And who is taking care of the stings?
Mhm.
Whether the hospital administration or the responsible primary consultant, we don't know. We don't know who is responsible for this, of not implementing. You rightly said that prophylactic antibiotic. How many surgeons are following it?
Mhm.
Post-operatively, for a week, we are continuing the antibiotics. If suppose we are going and tell to our own surgical colleague, they say that my patient is important. I don't want to take any risk. So
Mhm.
my patient is covered with the broad spectrum antibiotics for a surgical prophylaxis.
Right.
The entire community is spoiled. The entire hospital quality is spoiled.
Mhm.
And who has to take the responsibilities? If suppose the quality measures are not followed in a hospital,
Mhm.
do you have any structure to punish our doctors or to tell them that you are doing wrong and you are punishable, you are responsible for this? No. Only the guidelines we are able to postulate.
Mhm.
Whether they are following it or not, there is no strict responsibility from the hospital administration or our own colleagues.
Mhm.
As an anesthesiologist, as a perioperative physician,
Mhm.
who is more interested in the nutritional support for my surgical patients,
Right.
I'm not able to implement my nutritional things.
Mhm.
For example, I say incisional hernia, obstructed incisional hernia. It was reduced intraoperatively. Patient
Right.
passed motion intraoperatively, but the
Mhm.
patient was kept with the rice tube post-operatively. Since the rice tube is raining
Mhm.
1000 ml, 1500 ml, the patient is not fed at all.
Mhm.
The patient was kept in the nil per oral for 15 days.
Right.
As a perioperative physician, I'm saying that clamp the rice tube. Don't worry about the rice tube aspirations. Start feeding him. He will be all right.
Mhm.
Nobody is there to take it up.
Okay, man. I think
Post-operative delayed
that's
nutritional
going on and
support
on,
is
guys.
prevailing
We're wasting
everywhere.
time. PCV, you are, I think, deviating from the whole concept of quality and thing. I think
Why?
let people also.
Why do you
let-
think so? Why do you think so? This is what's happening. See,
Yeah, I
there are
get
some
you.
people like him
Dr.
saying that
PCV,
this is waste of time.
No,
No,
it's
no,
not waste
This
of
is
time.
how
We
we
have
have to
limited
improve the
time for
quality.
everyone. We're not saying we got the your gist. We got the gist
You
of what
talk
you're
for
saying.
10 minutes.
Yeah.
You are not able to allow other people to talk 15 minutes.
Mhm.
That is the where. The tradition, if you
PCV,
want to change, you have to listen to other people. When you
Dr.
don't
PCV,
have the time to listen to the other people, the tradition won't change. Dr. Shiva, I know about you. Just listen what the other people are saying.
We listened, man.
And,
Yeah,
and you are not a moderator. You are like me as a spectator.
Yeah.
Don't resist
That's
me.
why
It is the
I'm
role of the
getting
moderator.
bit bored.
Let them do that. If
Yeah,
suppose
you
they
need to be
think that
democratic.
I'm taking the more time, let them decide.
I think we should agree to disagree. And Dr. PCB, your point is well taken. Who's going to bell the cat? So, Dr. Ankur or Dr. Manjipuri, do you have any answers? So, who is going to bell the cat?
Yeah. Let me first, agree with Dr. PCV. His frustrations are not uncommon. Dr. PCV, believe me, the surgeon in your unit also has similar frustrations. right? The surprising thing is that we do not understand that these are patterns. Surgical safety checklists, or safe birth checklists, or for that matter, many checklists which were meant to be used as a job aid, have become pure documentation exercises. And as you rightly pointed out, in many places, they are filled post facto. So rather than being a job aid to help you remind of the critical things to do before, during, and immediately after a surgery, they become a document which is necessary to keep because somebody will come and check whether this document was filled and signed or not, right? In all of the things you're telling me, see, the fundamental point is that, like you said, who is responsible for quality of care? Who takes the responsibility of quality of care? My understanding is that healthcare systems, they are complex, but as an individual clinician, I might not have control over many systems. It's okay to say that the system does not allow me to perform, but it is not okay to ignore the fact that I am also a part of the system. There is a subsystem that I control. Am I looking at that system of care in terms of processes of care and outcomes of care? Am I taking responsibility of that system of care to improve its performance? I think there lies the key. It's common in complex systems that each one ends up blaming the other or feels helpless, and ultimately the quality does not improve. The way out is by understanding what is my small sphere of influence within this complex system. What is it that I have control over? What are some other people who could work with me, and try and improve that small system? So even though there's a lot of apathy in healthcare systems, the examples of small good work, like the ones that I showed you, they were in similar frustrated, complex healthcare settings. But these small examples ultimately encourage people to, adapt, encourage people to change and change for improvement. That is really where the change is going to come from. And I would take a moment to also recognize one of the comments where somebody has wished that changes should be coming from top. Now that's a problem, in pure systems approach. Complex adaptive systems like healthcare systems do not really work when it's only about the control function on the top. What actually works is decentralization. What actually works is agility on the ground in the hands of people who control it. If I continue to follow a certain process of care just because this is how things are done here, even though I know that the latest evidence-based guidelines recommend something else, then something is wrong with the system, which is not allowing me, a physician or a surgeon or a nurse, to do the best of evidence-based science, right? So systems require that agility, they require that decentralization, and that is why I propose we look at the approach differently. Rather than leaving quality in the hand of leaders and in quality departments, it is about taking control of quality of care in the small sphere of influence, in our own unit, in our own small team. Thank you.
Dr. Vidya, you have your hand up. You want to say something?
Yes, thanks. Thank you. It was a very wonderful, simple, clear, and easy flowing deliberation. For example, we did talk about looking at quality as an adherence to guideline. Maybe only 50 to 60% of times people adhere to.
Vidya, voice is breaking. We can't hear you well.
I think your bandwidth is giving you some problem, Aditya. Maybe you should move somewhere else.
Yeah.
Yeah.
There you have some guidelines that are based on high quality evidence and some that are not based on high quality evidence, but they're still strong recommendations. Just taking the point of antibiotic administration. The early antibiotic administration, and I've always tried to give it very, very early. within 1 hour, which is what we do. But then if you look at it clearly, it's not based on high quality evidence. And the IDSA guidelines now clearly say we have to have a rethink. The reason I'm saying is that there, within 1 hour, you can't really say a patient who's in shock, whether he's actually septic shock or cardiogenic shock. You need some time to really make it. And there have been instances where there's been people in my unit who have given antibiotics in 1 hour, and there have been some very nice registrars who put a thought to it. They've decided and probably ended up giving antibiotics in, say, 2 hours. And I've been asked by my people looking at the quality and say, why don't you talk to this registrar?
So, Didipya, I think your network thing is really bad. So we are not able to hear you at all.
Decrease. So,
Didipya, we can't hear you at all. So adherence to guideline, using all quality improvement is not about just finding out how much you're adhering to guidelines. So Preeti, you had something to say, Preeti Jolly?
Yeah. Hi, everyone. Sorry, I cannot be on the video, but I'd just like to thank Dr. Sooden for a wonderful presentation. And I just want to give a brief introduction to myself. I am a physician and endocrinologist, and I have also done masters in healthcare administration at United States. So I do have a little bit of experience in quality. And what Dr. Sooden was saying was wonderful. And what I do want to say, just as, my little 2 cents, that quality improvement is all about systematic and systemic care of the delivery of healthcare to patients. And it has to come vertically downwards. So if we try to analyze that, who are the actual people who see the problems is not the top management, that is the top 1%. No, we just have to come down to the front line and see how we can actually come down to those people that understand how the workflow and the processes happen. And if we are able to come down to the frontline workers, we will be able to come to the root cause of the problem and the processes that we are encountering in our daily practice. So I think that is the most important thing. And also, change management is very hard because any change is very difficult. I think it all requires going from bottom upwards and then following it in a systemic way where the best care at the best time is given to all the patients. I think that's what I'd like to say. Thank you very much for a wonderful presentation.
Thank you. Thank you, Preeti. If either of you would like to respond to all the comments that have come in the past few minutes.
Yeah, so, I think excellent discussion. And Dr. Preeti has actually summed it up the way, we were trying to I was trying to look up because I'm not an expert at it. But I think what is important is that, we need to understand that it is not only, looking at the guidelines. It is more about, understanding why a problem is happening. And it is not that quality improvement gets initiated only from adverse events. It is whatever you are doing, you are trying to improve that. I think that is what it is. So if we are not happy with something, we try and fix it up in our with our own resources. And I think there will be another session wherein we will share our experiences as what we have done, which was as a part of quality improvement. So thank you, Dr. Vidya, for having me here. And it was indeed a very, very...
So, Shiv, we were trying to share a slide. Do you want to show something? Shiv, you're trying to share your screen. Yeah, meanwhile, Dr. Ankur, if you could, elaborate a little on some of the very small, steps that led to big changes. I think, you've covered all the theory parts, so maybe a few examples from your personal experience of QI.
Right. So, my entire learning of quality improvement has been from healthcare providers. In my experience of the last decade or so, I have learned how to improve quality of care in different contexts from the people who improved it in those contexts. right? One of the things we must do is simplify, make it easy for everyday healthcare providers to understand quality concepts and to be able to practice those concepts. One of the challenge with most quality improvement approaches have been that they're very complex. There's a lot of jargon. There's a lot of management jargon there, which an everyday healthcare provider is not able to make sense of and could not care less about. Right. So one of the things we did realize much early is that if I am to help a healthcare provider understand quality improvement, I can't use jargon. I can't give a sacrosanct method that they have to follow. The only thing that helps much better is giving them an example of somebody in similar settings who did this despite all of the challenges that might have existed, right? So explaining quality concepts using examples is a much better way. I wish I could tell you as many examples as I remember, but you must read those examples up. A lot of them are published, and use those examples to help healthcare providers learn quality improvement. So if I am to go to a healthcare facility, to a unit, and I'm tasked with teaching them quality improvement methods, I do not talk any jargon. I start with a story. Usually I don't even tell the story. I invite somebody who's improved healthcare in a similar setting to tell them a story. Healthcare providers, there's a very famously studies concept among healthcare providers that they listen only to their own, preferably to the ones who are in similar setting. Very natural, right? That's what any highly specialized profession would do. So finding out who's done that, making them talk to those people, and helping explain quality improvement concepts in terms of how somebody similar did it in the application of concepts rather than in the in the knowledge of it. I think that's important. That aligns with adult learning principles. Anybody who spent considerable years in a profession cannot be taught quality improvement in a classroom method, at least not initially, right? They have to be taught in a manner where they understand it in terms of the work they do. Like, let's say I am a nurse whose duty is to attend to the clients who come to an examination room. Help me understand, all these concepts in a simple manner on how I can apply it tomorrow. If any quality improvement education method doesn't do that, there it will fail. And that's a reason why quality has, for long remained beyond the reach of clinical providers. And actually, many clinical providers are also disinterested in quality, because in the name of quality, you make me make tons of registers, make me want to be available for for an inspection that is to happen. I do not relate. I, as a clinician, relate more to the clinical care I provide. But the fundamental mistake I, as a clinician, make is that I do not look beyond the individual case. I see the 10th case with a surgical site infection in the month, and I still do not realize that I have to look at the rates of my surgical site infection. So amount of quality that will be improved in a unit is a function of amount of quality improvement concepts that a healthcare provider knows and is able to apply. That will require giving them a purpose, that will require building their skills, that will most importantly require giving them the autonomy to do so. So those are top level functions, right? Yeah. So I hope I made sense with what I said.
Yeah.
Vidya, can I share the screen
Yeah.
then? Can I show
Sure.
some few things here? Let me share that. Sorry, what are you saying? You're not seeing some?
No, nothing.
No.
We were seeing something before, but right now we're not seeing. So meanwhile, if anyone has any questions or comments, please either type them in the chat box, or you could raise your hand or use electronic hand raise or whatever.
I don't know what's happening. So it was actually basically about the change management. It's got a lot of things, but one other important thing was that how the people are classified into, there is a group of innovators, then they are early. Let me see if I can share it again. Um,
Uh,
no, it's not. It's not happening.
okay,
It's okay.
never mind,
Yeah,
never mind.
yeah.
So-
Don't worry about that. So yeah, so there are early adopters, and then there are early majority, late majority, and laggards. Now, these innovators are very small amount, they're 2.5% or so. The early sort of adopters are 13.5%, and 1/3 are early majority, 1/3 late majority, and around 15-16% are laggards. Laggards are one who will say, I'm not going to change. I'll keep doing it. I've been doing it for the last 50 years like this. I don't want to get change. But it is the innovators and early adopters. They said that if you can actually get around 20% of these people onto your side for a change, then rest becomes easier. It will actually follow on. And I think there were very good examples of, given before that, how somebody is trying to introduce quality improvement like checklists and things, and they're having resistance. But that is going to happen. It has happened everywhere. Even in UK, when the WHO list came in, it wasn't immediately that everybody was following it. Some started, then there were presentations, then everybody came together and then presented how we have improved things. Without that, it won't actually happen at all. We need to actually show that. The other things is that you need to actually modify the things according to your requirements, the local needs. Otherwise, the adoption doesn't happen. So you can't just take a checklist from UK or US and try to implement in India. It might be slightly different. You need to modify it to your specialty, to your hospital, to your state, your city. And that's what leads to adoption. And I think the thing which actually helps is sharing your success. That doesn't actually happen easily. If you share the success that we were able to do it, it was difficult, but we were able to do it. And that's what I think forums like this actually help.
Right. Thanks, Shiv. We have your namesake, Shiva Pillai, logged in from South Africa. Shiva, would you like to say something?
No, fantastic talk. What I wanted to say was that, the initiators of what is called quality assurance comes in many guises. If you got financial people and management initiating quality assurance, they have got a particular reason for doing it because of cost control and things like that. Then you've got management who wants to increase the work production of staff. So they come up with the guise of quality assurance. But the concept of quality assurance is a fantastic concept. We fortunately have systems which is called benchmarking. You have to give reports on the audit of what is happening within your hospital, and your hospital actually gets publicly rated. Not all the hospitals have volunteered to do that. Fortunately, my hospital has volunteered to do that, and I think that is very helpful. But also, we need to say that quality assurance is a very subjective matter. Also, you see, when we went and did it first time, we thought we'll improve quality by taking patient satisfaction survey. And we interviewed post-operative patients and we asked him, how was your care? Who took care of you the best? And this is a joke, but they said the anesthetist was the only one who cared for me because asked me when did I last eat. So in that patient's eyes, quality is different from what we think is quality assurance in clinical medicine. So you need to get a balance between the both, between efficiency, quality assurance, clinical outcomes that is better, and bringing about a more efficient system. And anything that does that, it is going to help. So what we have asked and what we have found also, when we put out this checklist, after a few years or so, when things happen, in pre-anesthetic, everybody is ticking that list. If you go to the nurse and ask them, okay, why did you ask the patient when did they last eat? They will look at you and stare because they don't know the significance of it. So if you teach people the significance of why they are doing things, and they understand why they are doing things, you find it's better for them to comply. That is one of the things about change management, is to make people understand why they are doing things and what they are preventing, and what sometimes you have to reinforce them by saying, do you know you prevented an aspiration by checking this? And then it becomes reinforced and it makes a better system to work. But you have to have the system in place, and then you have to look at how to improve it, and you have to see how it is working. Very important to think, is your system working, and is it making a difference? And if you can do that and you can make it relevant, then it's worth it. Thanks.
Dr. Siva, can I just come in? I feel that, in addition to understanding why someone is doing things the way they are doing, it is also to understand why they are not doing. I think when we look at quality improvement, we focus more on why they are not doing, and then try and understand and fix that aspect of it. That is what is my understanding. Ankur, do you want to comment on that?
No, you're absolutely right. Why are you not doing certain things is also very, very important. Why didn't you put the catheter before the patient came to theater? Why are we putting the catheter in theater before a cesarean section becomes very important thing. So the positive aspect, why you are doing it, or why, if you don't do it, what is the consequences, and why your omission and commission basically is what you look at.
Dr. Manju, the way I, in my experience, what works better is rather than asking them why you are not doing, I usually try and reframe it and ask, why are you not able to do this?
Yeah, agreed.
Implying that there is something in the structure and systems which is impeding you from excellence.
Okay.
Right. So the moment you ask that, the shell breaks. Now the person is not trying to protect themselves. They feel safe. And then they talk about all of the challenges they face in terms of how structures of care and how processes of care are there, and they are able to identify that. So that inculcates systems thinking.
Perfect.
Dr. Venkatesh, you have your hand up?
Yes, ma'am. It was an excellent talk by Dr. Ankur Sooden. A lot of concepts, a lot of learning, and particularly the discussions that were raised later on answered many of the questions that I had in my mind. But I would like to put one particular question. See, for example, I head a nephrology department in a small-time hospital. But we are also part of the NABH. We wanted to acquire. We gave ourselves this idea that we should improve our quality, and we looked at how to get yourself. Getting an accreditation would be a useful way of doing it. It's a very small team of people, so we all kind of like-minded. But one aspect that we got into trouble is when the accreditation board comes for an inspection. They have a certain set of guidelines. They expect us to be slaves to those guidelines, and that becomes a problem. In fact, the dialysis water quality assurance, which we wanted to plan in our unit, was not a deviation from what is practiced from the world. But we actually did a pilot study saying that what frequency of sterilizing the unit would be appropriate for us. Based on that experience, we said, this is how we do it. And these are our set of standards, and we are strictly following our set of standards with good outcomes to our patients. We are showing them the outcomes are relatively good, and we're very happy with it. But then that these accreditation agencies, they have a very different kind of approach to it, and they raised non-compliance on certain issues, and they put this as one of the thing. And what we did is I sent a series of documents saying that what pilot study we did, what was their outcome, and why did we come to this frequency of cleaning our unit would be appropriate. But then that became, still they persisted, that they insisted that we should follow what they follow in the United States. And how do you deal with these kind of issues is another question that comes to my mind.
So, Dr. Venkatesh, thank you for sharing that. I'm also an external assessor for a national quality assurance system, and I understand your pain, right? Imagine having just one checklist for every kind of nephrology unit that might exist in this country. And you can well imagine that it can never be perfect, right? That one size would not fit all. Even though quality assurance agencies, they say that, the quality assurance checklists are standard, but then its application is contextual. So an assessor must look to the intent of a standard rather than, the actual words of a standard, which sadly did not happen in your case, right?
Yes.
So, what I can assure you is that, see, there are reasons to get NABH certified as an individual unit. You would understand the benefits of it in terms of the clients wanting that, or also in terms of the compensation agencies pay you, right? And there it might become important to, I don't know, comply with those guidelines, right? If it is not unethical to do so, right? You would still comply with those just to get the certification because it is necessary for business. But otherwise, I tell you, quality assurance serves its purpose, right? It gives you a template to check yourselves against. But in terms of improving quality of care, it's just the beginning. The measurement is just the beginning. And the problem is many hospitals, unlike yours, they think getting certified is the end of it. To my understanding, a measurement by an external person is probably just the beginning of it, because that is where you will realize gap and start to fix it. So quality assurance typically, or any certification typically, is like an exam you give. I guess most of you did your medical education in India. It's like the entrance exam, or it's like the exit exam. I'm not sure whether great scores in an exit exam, which happened on one day on one set of questions, makes you a great clinician. The knowledge and quality improvement is about making it better, and continuing to do it better and better. Whereas, using a checklist to measure the quality of care on a particular day, a static measurement for a very complex and dynamic system is always going to have its shortcomings. It still is useful in helping you identify some of the gaps and filling that. It works better if we apply the checklist on ourselves, right? If we do self-assessments to figure out our gaps and identify our issues, to solve them, do that against standards or do that against benchmarks, right? Sadly, I might sound a little critical of quality certification, but that is my biggest qualm with that. I, as an assessor, will come to your facility with absolute no idea on what latest evidence-based practices in nephrology are. I use a standard checklist which is used across such a varied country, and I tell you how much you score. I fundamentally disagree with that. I think the control of quality has to be in the hands of clinicians.
Absolutely, sir. Thank you. Thank you so much.
Dr. PCV, you have your hand up?
Yeah, just in continuation of Dr. Pillai's comment. See, those days when the anesthesiologist go and ask our surgical patients, when you had your food. So that question, just to ask them when they had the food, if suppose they had the food, in the sense they had a 200 ml, 1 tumbler of water, it's an intention that to cancel the case. The anesthesiologist will cancel the case for taking 200 ml of water 2 hours before a surgical procedure. It's not the fault of the anesthesiologist. In those days, we thought that 200 ml water can cause aspiration when we are inducing the anesthesia on a surgical patient. So that's for the safety. We all know that quality is equivalent to safety. So in those days, we used to ask each and every patient, when you had your food, suppose they are saying that 200 ml of water 2 hours before a surgical procedure, cancel the case. But now the evidences are very strong. 2 hours before, you preload carbohydrate to a surgical patients. That has a good benefits in the post-operative period, in the perioperative period, and that is the safety and that is the quality. So the traditions has to change. Now, if you're going and asking a patient, when you had your food, the patient says, I never had any foods. For the last 12 hours, overnight, I'm starving for a surgical procedure. Then the anesthesiologist should say that, why are you starving? Overnight, take 400 ml of free carbohydrate loading. That is good for you. That is the evidence, and that is the quality, and that is the safety. And the point which I like to convey to the entire audience who had listened to 1 hour lecture, to improve your quality, You all should change your traditional practice with the evidence-based practice. If the evidences are strong, don't hesitate to change your tradition. Thank you.
Dr. Rajiv Tiwari, we'd like to hear from you, sir.
Yeah, Vidya, it was an excellent talk, an excellent discussion. Definitely, we all learned something from this talk. What I feel that it was very important that what you want from others, you have to practice yourself and make it an example by telling them that this is the way how you have to do. And it's very rightly said that if you practically you perform something, you are asking them to do this thing and show it to them, they will learn it better. Just by giving the papers and telling them on face, it is not very important. So this is my view, and it is perfectly very well discussed topic here today. Thank you very much.
Thank you, Dr. Rajiv. Dr. Shanti Mallar, did you want to say something?
I think I've sent a message to all. Thank you very much. I am from Guatemala to Government Service, Tertiary Care.
Yeah, please go ahead and speak. I mean, we'd like to hear from you.
Yeah, this is very nice lecture given by Dr. Ankur. As I have messaged already, this is as per Dr. Preeti Jolly, this is starting from the frontline healthcare service providers is the important thing for the provision of these healthcare services to results. That is, whatever you are providing, the results should be the outcomes. So, olden days, we don't have access at all. Now the access is better. Quantity of these services are better. Slowly, the quality we are reached already, but the outcomes now only we are concentrating on the outcomes. So frequent sharing of the both negative and positive results along with the team is most important actually. So definitely we can derive solutions to improve the whatever based on the scenarios, that too especially the local needs to be actually accessed. That is the important thing. Thank you very much.
Thank you, Dr. Shanti. Radhakrishna, we are kind of out of time, so we'd like to wind up your comments.
Yeah, an interesting lecture, I should say. But again, as Dr. Ankur mentioned in the discussion, this looks like more like a management lecture to me with all that jargon, which usually the healthcare people talk among themselves. I don't understand most of it, actually. I was looking for orange juice when it's provided me oranges. As clinicians, we want to go more to the brass tacks and see how our quality and where we work and what are quality parameters which we should improve. These are all very, very broad managerial terminology. And then coming from a country where, when we don't follow traffic rules and we don't stand in proper queues in airports, I do not know how we can ever be disciplined to, improve quality. We're all, as clinicians, we are bothered about what we do or our unit does, but we are just not bothered about what others do and what's happening to the hospital statistics. I do not know. This may be genetic or this may be a brought up, whatever. I think a lot of things should improve before we all keep thinking about how to improve quality. I think just like the way we do a weekly clinical audit, I think we should also do something about quality audit, where we should identify the small quality parameters and audit them, and there should be a quality champion among every unit or every setup who will, just like the infection nurse who picks up those data. Frankly, I mean, wherever I work, there's an infection nurse who's taking all the statistics, but she keeps to herself. I do not know as a practicing surgeon as to what are the outcomes and how does it, affect my clinical practice. So I think, these things have to be driven at a younger age in undergraduate level to, talk what's all how quality matters in medicine. And it's a long, long way. But altogether, it's a wonderful session and much needed at this point of time. Thank you.
So, Venkatesh, you have your hand up.
Sorry, ma'am. One last question. How to become a quality assessor? I hear that it pays well.
So, yeah, Dr. Venkatesh, I can answer that. So, quality assessment, there are systems for quality assessment. There are at least 3 or 4 in India right now. NABH runs one, wherein quality assessors usually are from the same clinical field. National government runs an NQAS thing where they every 2-3 months they have a training where you can be trained an assessor for public health facilities, and then there are others, right? So as a clinician with experience, you don't need anything else. You have to reach out to them, you enroll them. Assessors usually are meant to be clinicians working in the same or similar fields. So they do a small training. Basically, they help you understand each checkpoint in that assessment checklist, help you practice in a couple of places. Maybe you do a shadow assessment with somebody else. And yeah, by then you are trained as an assessor. It's a great thing to do. I would recommend doing it, particularly because it helps you learn how healthcare is delivered differently in different contexts. It's a great learning experience. At least for me, it has been. Yeah.
Are there any exams, sir? Are there any exams for the assessor?
They do have an exam, but don't you worry about it. With the kind of interest you are showing, you'll easily pass that exam. You have the intent.
So
Thank you.
Radhakrishna, to come back to your thing, we are going to have a follow-up session where you said you want orange juice, so something like it,
Yes.
different types of juices. We'll be doing a follow-up session where what kind of problems were tackled using QI tools and what results came up. We'll be doing that in the next month. One session we'll have on. We might have quality related sessions more frequently now.
But yeah, I think Dr. Vidya, the point by Dr. Radhakrishna is very valid. A quality expert speaking to clinicians does not make sense. Let clinicians tell clinicians how they improve quality of care. It's a known fact. It's a very well evidence-based fact that the only way clinicians are going to learn to improve quality is by listening to other clinicians who improve quality. Once they gets them interested, the concept, the jargon can wait. I was slightly surprised that I've tried to avoid jargon. Believe me, a typical quality expert would have had much more jargon. But thank you, Dr. Radhakrishna, for your feedback. There still was quite a bit jargon, and I guess it would work better if we only talk of quality improvement in terms of from the viewpoint of a clinical provider, rather than a manager or a quality improvement expert.
Right. Your closing comments, Dr. Manju.
So basically, I think, at the end of it, I think that still that quality assurance and quality improvement as two different entities are still apart. And I think the next session which we have, wherein we are going to share our experiences as clinicians, maybe, that will put the whole thing in more correct context. And maybe then people can understand what we are. That will be a more simplified way of explaining how it works. And it does work. And it is different from quality assurance that also is absolutely there. And both have to coexist. I think that is what is most important. Thank you so much, Vidya, for having us here. And let's hope that we'll make things more clearer and have people discuss it more. I think then things become more clearer. Yeah. Thank you.
Thank you, everyone, for being very interactive, for a very interactive session today. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.